Good afternoon, everyone, and good morning to our West Coasters. My name is Sabrina Corlett, and I am a research professor and co-director of the Center on Health Insurance Reforms, or CHEER, at the Georgetown University McCourt School of Public Policy. I will be your moderator today as we delve into the factors driving hospital financial health. I am super excited for this first installment of our new webinar series for lawmakers focused on hospital finances. For those of you not familiar with our center, we are a team of national experts on health policy in the commercial market. We study the interplay of federal and state policies that affect how people access and use healthcare services. We publish numerous research studies and reports, and we also provide technical assistance to federal and state officials and other healthcare stakeholders. Before we begin, I want to thank the sponsors of today's event, Arnold Ventures, and go over a few quick logistics. First, this webinar is being recorded. Everyone will receive an email early next week with a link to the recording, as well as any slides and resources we discussed today. The recording and slides will also be posted to our website. Second, this is not a press call, so if there are any members of the media who are on the webinar, all contents of this conversation are off the record. Third, the chat is open now, and we will remain open, and we encourage you to use it to introduce yourselves, share reactions, and connect. And if you have any technical issues, just drop those into the chat as well, and our producer, Katie Sargent, will do her best to help. Finally, we've set aside a bunch of time for Q&A after the presentations. When we get there, we'll be taking questions that are submitted using the Q&A box at the bottom of your screen. You can drop your questions into the Q&A at any time during the webinar, and we will do our best to respond to as many of those questions as we can. Now that we've covered those details, I am delighted to introduce today's terrific speakers. We are joined by Kyle Brown. He is a state representative for Colorado's 12th district. Kyle has a long track record of advancing policies that expand access to quality, affordable health care, and he previously served as a senior advisor to U.S. senators and to governors before joining the Colorado legislature. Tyler Brannon is a senior health economist at Barry Dunn, where he advises state governments and nonprofits on healthcare financing issues. Tyler has extensive experience helping state agencies, nonprofits, and policymakers understand complicated healthcare financing issues and guide effective policy. He previously spent 16 years at the New Hampshire Department of Insurance. Today's conversation is such an important one to be having. We all know hospitals play a vital role in delivering healthcare, and we've all heard that hospitals' operating margins have been squeezed in recent years, particularly coming out of the pandemic. We also all know that hospital care is expensive. It accounts for about a third of all healthcare spending, and the cost of hospital care is rising rapidly. As elected officials debate a whole range of policy options to keep healthcare affordable and accessible, many have considered strategies that would impact hospitals' bottom lines. These include protecting consumers from aggressive hospital debt collection, promoting competition within hospital markets, providing funding to hospitals that are struggling financially, cost growth benchmarking, public options, and more. But for the most part, policymakers are doing this work in the dark because there is little information out there about hospital finance. We're here to change that. Over the course of our three-part webinar series, we hope to shed light on the factors that influence hospital finances and give you the tools you need to understand hospital revenue, operating costs, and overall financial health. Don't worry, this is not a technical talk where we walk you through a hospital balance sheet. Instead, you will leave this call knowing the fundamentals of how hospitals are financed and the financial incentives and pressures that they are juggling so that you can be more confident in your policy. And that's why we've enlisted the help of our two terrific speakers today. We will hear first from Kyle and then Tyler before opening up to your questions. I will let I'm sorry, I'll let Kyle take it.
Great. Thank you very much, Sabrina. I really appreciate being with all of you. This is a really topic that I'm really passionate about, and it's something that I've been able to work on throughout my career. In Colorado, we have a long history of trying to add transparency and collect data on really healthcare costs in general, but definitely hospital finances and hospital costs. You know, this work goes back to 2010 when we passed our law to create an all-payer claims database in Colorado. And since then, we have implemented a number of different initiatives to try to understand the finances of hospitals. In the mid 2010s, in about 2014, 2015, we started really digging into to the Medicare cost reports that all hospitals produce. And the Department of Healthcare Policy and Financing in Colorado, which is our Medicaid department, just started to really to dissect them. They're very complicated, and it takes a lot of effort and understanding. So we were on the forefront of that work. In 2017 and 2018, we ran bills that were at first unsuccessful. But when Democrats took control of both the House, the Senate, and the governor's office in 2019, we were able to pass a bill to require hospitals to provide additional financial information to the Department of Healthcare Policy and Financing so that they could continue and build upon the financial reporting work that they had been doing. At this point, the Department of Healthcare Policy and Financing in Colorado has developed a break-even analysis on their website for different hospitals and provides different information about the financial health margins, price, cost, and related to all of the hospitals in Colorado. This data has been invaluable as we have discussed different innovative healthcare approaches. Colorado has been fortunate to be on the forefront of a lot of the most innovative healthcare programs in the country, including a public option, which we call the Colorado option, and a program known as a Prescription Drug Affordability Board. None of these programs would have been possible without incredible data resources that we have, both through the APCD as well as the hospital cost reports. In particular, the hospital financial transparency allowed us to develop a formula for hospital reimbursements that is built into the Colorado option. So to understand where hospitals were getting paid, or how much they were getting paid versus how much maybe they needed to break even, and to set a reasonable level of reimbursement that would allow us to control costs through the public option program. That's just one example that we worked on in Colorado and how this data has been super effective. So with hospitals taking up, as Sabrina mentioned, about a third of our overall costs, and in the commercial market it being even more, we really need to understand how hospital finances, how hospitals' finances are faring, where the particular price points are, so that we can design policies that will help us to maintain quality care, access, and make healthcare more affordable. So with that, I will go ahead and turn it over to Tyler, and I really appreciate you all being here and listening to kind of the story of Colorado here.
Good afternoon, and thank you. I am Tyler Brennan. I am a senior health economist with Barry Dunn, and I will be giving you an overview of some of the factors driving hospital financial health. This is a relatively short presentation, But some of the areas I'm going to cover today included here. Talk a little bit about hospital types, consolidation within the industry, focus a bit on hospital costs, talk about financial indicators related to hospitals, and then wrap up with a little bit about rural hospital and some of the considerations there. The first thing I want to bring your attention to is the top right corner of this chart in that blue area. When it comes to national expenditures, we can see that hospitals are about a third. And if anything, this is an understated amount. When you think about how much hospitals have invested in our healthcare system, they own physician practices, often directly or indirectly through another organization that often the same hospital leadership has significant influence over. They're also investing in other types of providers and parts of the system. So when we're thinking about policy initiatives or legislation that's going to impact healthcare costs, it's pretty hard to ignore how large hospitals are as a part of this overall amount. So some of the common hospital types, and you'll hear the terminology out there, and I wanted to make sure you were familiar with what each might mean. The first is at the highest level, we're talking about nonprofit or for-profit or public hospitals. Nonprofits are most common, and you will see that people refer to hospitals, particularly general hospitals, in a few different ways. Short stay hospital is a term that's actually defined by CMS, or the Centers for Medicare and Medicaid Services. You will also hear acute care hospital or acute care general hospital. And then, of course, community hospital, which may be in the actual name of the organization. Looking to the top right, you can see academic medical centers are part of our delivery system. In some ways, they are what they sound like. They are integrated with a medical school, that contrasts with something that might just be a teaching hospital. They're usually larger organizations offering specialized services and do things that many other organizations don't. Academic medical centers are almost always in their own category. If you're looking at hospital comparisons, they're usually separated out, appropriately so, and their world's a little bit different. They do receive additional funding from Medicare for being an academic medical center, and they do function a little bit differently. We have specialty hospitals. There are a few examples listed here. There are many others: pediatric or children's hospitals, the rehabilitation hospitals, psychiatric hospitals. Specialty hospitals are not completely without some controversy, though. At one level, they could be seen as competition in healthcare and competing with a more general hospital, and that can be seen as a good thing. However, in some cases, specialty hospitals can be seen as pulling away some of the more profitable services from the community hospital. So if those more profitable services are moved to a specialty hospital, it becomes more challenging for the community hospital to maintain all services, including those that they may lose money on. The specialty hospital equation becomes a little more complicated when physicians are invested in the specialty hospital, particularly physicians who may be able to influence the referrals or the care that ends up at specialty hospitals. The lower right corner, we've labeled it as CMS designations, but you will hear these types of hospitals being referred to as a type of hospital. And in many ways, they are quite different. Certainly the most common is going to be a critical access hospital. And these organizations do receive some additional funding from CMS in order to maintain their operations. And their funding structures are a little bit different, actually, in a few ways. But they have to maintain certain criteria. They have to be 25 or fewer acute care beds, and they have to be at least 35 miles from another hospital. The rural emergency hospital is a relatively new designation, but I want to include it because it is sort of a natural evolution, I think, of our healthcare system, particularly in communities where they may not be able to maintain a hospital that offers a full range of services. CMS came up with this designation, provides additional funding for the organizations, but they are limited in the types of services they can provide. That being said, it is a way for these organizations perhaps to maintain key services in those communities where they are when they may not have been able to otherwise. One of the other big things that's taking place is private equity and its investment in the healthcare system, and that includes hospitals. It has a growing presence, and private equity has received a lot of media coverage, very little of it favorable. There are concerns about the relatively short cycle expected with private equity in terms of their investment. the changes they may make, and then they may exit their investment. Typically, what we see or the evidence supports that private equity results in higher prices for those healthcare services. Obviously, a part of the model is reducing costs in order to make the organization more profitable in what could be considered a short term. That being said, private equity perhaps provides funding streams that wouldn't have otherwise existed. And this is true perhaps in some communities where those hospitals were struggling beforehand. That being said, we're going to see additional attention on this issue. And certainly some legislators have taken it upon themselves to introduce legislation that would restrict private equity's investment in healthcare. So we have the first polling question. While private equity is a conversation that's a bit lengthier than what we're going to have today, we see what you think about its investment in healthcare and hospitals. I should be able to see the results on this. Clearly, there are some concerns about its investment. So one of the main things when we're talking about hospitals, we're usually talking about hospital systems. These may be systems that include multiple hospitals. More likely, it includes hospitals and other parts of the healthcare delivery system. This statistic of 92% of all hospital beds being in health systems was taken from a study a few years ago. So if anything, that number is going to be higher today. Typically, if we're talking about hospitals, just remember we're talking about hospital systems. Physicians may be employed directly or through an organization that is under influence or control by the hospital, typically with the same leadership of the hospital. The financial statements, which are considered the gold standard for looking at hospital financials, they may be at the hospital level or they may be at the system level. It does become fairly complicated going through some of these financial statements to understand or fully understand what you're looking at. These systems are the results of mergers and acquisitions that have been taking place over a long period of time. This is nothing new. There are a number of reasons for this consolidation. Certainly from the hospital point of view, there are a lot of advantages. Clearly getting access to additional resources is going to be one of the big ones. It comes down to improved economies of scale and purchasing power. So if you need an HR director for your hospital, perhaps you can get away with one HR director for 6 hospitals instead of 6 HR directors for 6 hospitals. It's one of the economies of scale that may come out of joining a system. Purchasing power comes down to the things hospitals buy. They obviously purchase a lot of materials and supplies and other things. Clearly, if it's an organization that's 10 times as large as an individual hospital, they're going to be able to negotiate more favorable pricing for those items that they are buying. And these are opportunities to reduce their costs. That's internal costs. You do have access to more specialized healthcare providers and administrative expertise, advanced treatment equipment. And if you look at the electronic medical record costs, that is the cost to acquire that software, it's easy to see how the products would be marketed just as systems. Since they are so expensive, it's difficult to imagine a smaller independent hospital purchasing them on their own. Obviously, they could access additional financial resources to get through lean years, or perhaps to make investments that will reap the benefits in the future in terms of revenues or other improvements when it comes to healthcare. A system can control patient referrals better than a single entity. That means when you go to see your primary care doctor, they may refer you to another healthcare provider within the system. That can happen when you're seeing a specialist as well. Clearly, that's an advantage for a system versus a patient that would go to a competitor outside of the system. One of the other big ones is that when a hospital or other healthcare provider becomes part of a system, they improve their negotiating leverage with commercial payers. If you put yourself in the shoes of an insurance company, they're selling their products usually to employers and a number of different things. But the provider network is hugely important when they're selling that product. If they're trying to sell to an employer, a network that doesn't include a major hospital or a healthcare system, good luck. So that makes it important for the insurance company to have a healthcare system in their network. And at the end of the day, that means they're willing to pay more for healthcare services to get that system or large provider in their network so they can turn around and sell a robust network product to employers that are obviously thinking about employees in a number of different locations. So there are some downsides to hospital consolidation. While there are potentially lower costs, that means internally to the organization. When the hospital becomes merged into a larger system, the evidence generally shows higher prices for private payers, and of course, patients when they're paying out of their cost sharing. Unfortunately, indicators of quality usually do not improve and even sometimes deteriorate. There is also evidence suggesting increased use of facility fees. So what is meant by facility fees? If you go to an individual physician, you would expect there to be a claim from that physician or that practice that is sent to your insurance company. You might expect to pay a copay or other cost sharing for those services rendered by the physician. If you go to a hospital setting, you still have the physician claim, and you also have the hospital facility claim. But what's happening more and more is that when you go to another site, could be a physician's office, but more likely it's something between a hospital and an individual physician practice, you're seeing more of those facility fees that you used to only see in the hospital setting. Clearly, if there are two claims instead of one, that's going to increase the cost. It's going to put upward pressure on health insurance premiums. And it also affects your cost sharing, which you pay out of pocket, because now there may be cost sharing applied to the facility part of the billing, not just the professional. There is also a loss of local control when an organization becomes part of a system. That system may be more concerned about some things that don't relate to the community's particular interests. Often when transactions take place, one of the conditions on the merged entity is often to maintain services, because that may not happen in other cases. So next we have our second polling question. Should see the results soon. Clearly, there are concerns about the prices after consolidation, but some mix of answers. So what are hospital costs? I could have had about 10 slides on this, but I reduced it down to one to make what I think is one of the more important points when it relates to hospital costs. Hospital cost structures are often considered fixed. Intuitively, this makes a lot of sense when you think about your last visit to a hospital. You go into a large, probably expensive building. You've got a lot of expensive technology that they may use with your care. You're being seen by a professional who probably went to school for a long time and is probably pretty well paid. These costs are fixed, meaning that if patient volume goes up or down, at least within a certain range, the hospital costs don't change much. This is an example of sort of fixed costs. That being said, what we do know is that if there are major changes in the patient volume, either up or down, the hospital will adjust its cost structure. Since about half of the fixed costs include employee salaries and benefits, it's not something that's always easy to do. That being said, one of the biggest predictors of hospital costs in the future are really going to be the revenues that they expect to have come in place. So when we look at the actual changes, the actual costs, we do see they're more like steps. They'll step up to new assumptions about patient volume and revenues, or they could step down to new assumptions about patient volume and revenues. It may impact service mix, it may require adjustments in a number of different ways. But it is one of the reasons that there's a fair amount of inertia for hospitals to adapt to changes over time. So what hospital financial measures are useful? And there are a lot of them, and I probably put too much on the slide to begin with. But one of the places to start is on both total margins and operating margins. And you will typically hear more about operating margins when you're looking at hospital financial indicators. It's typically what makes itself into the public domain a bit quicker, and it is perhaps a little more focused on the core operations of the hospital. That being said, total margins include additional revenues the hospital will receive, often from investment income, and it is a good indicator, in addition to operating margins, about the financial health of the hospital. There are liquidity measures, there are long-term debt, other debt ratios, average age of plant. Always good to know how old the organization and investments are. Clearly, if they are old, it's going to require some changes and some investment to bring the age of the plant up to current standards. It is important to look at these financial measures in tandem with one another. Days cash on hand, for example, is one that gets a certain amount of attention. And you can see how if they had a lot of cash on hand, that might raise some questions. Well, if you didn't look at the accounts payable, you might not know if they've paid their bills. They could have high days cash on hand. They could also have high accounts payable, in which case the two may offset each other if they actually pay those debts. The other things I want to bring your attention to is there are hospital credit rating agencies. Some of the more popular ones are listed here, and they actually do this type of analysis. They look at a lot of different financial indicators. They look at the hospital market share, other things that may influence the hospital in the future. They are coming up with a credit rating that is a understanding of how likely a hospital is to be able to pay back future loans and debts. The information is not always public, but you can usually get it one way or another. And indeed, some of these credit rating agencies, you can actually sign up on their website and see some information about hospital credit scores. So this is an older chart at this point that looks at hospital margins. It's one of the fewer that include both total margins and operating margins over time, fairly lengthy amount of time. And you can see that generally speaking, your total hospital margins are going to be above your operating margins. The exception was in 2008, when the market had such a poor year. You can see the influence of those investments on hospital margins. Okay, more current data, and this study was done to determine whether or not the COVID relief funding that was available for hospitals, at least many hospitals, offset the reductions in patient volume and the revenues associated at hospitals. So you can see through the years, the first takeaway again is that you've got your overall profit margin above your operating margin. And then in 2020, you've got that real drop. But because there was these relief funds, the overall profit margin didn't drop. Of course, these are averages, and they're done across a sample of hospitals. Every hospital's individual experience could be a little bit different. But the researchers concluded that yes, those COVID relief funds were enough, in fact, more than enough to offset the losses, at least in 2020. These are very current data. These are down by the month, and these are operating margins. Indeed, a lot of the national press has said that hospitals are doing much better now. They are coming out of the pandemic, and they are in a much improved financial position. Clearly, when you roll up averages, it may not tell the story of an individual hospital, but at the moment, operating margins are looking better. Remember, your part of the country may be a little bit different. Some of the data from my part of the country does suggest the hospitals aren't doing as well as some of the national averages suggest. These two slides, this one and the next one, came from a public hearing with Exeter Hospital last year, when Exeter was becoming part of a larger healthcare system. And there are a couple of the same takeaways from this. One of the other things you want to do when you're looking at financial indicators, particularly margins, is look over a period of several years. So here we're looking at operating margin with and without COVID provider relief funds. So they were pretty close to break even until 2020, and 2021 turned around better. When we're looking at total margins, you can see how things are better for Exeter Hospital. In fact, 2021 might have been a year that was so good it would bring a certain amount of attention to how well it was for them. That being said, in 2022, Exeter's margins were not so good. So it's important to look at these margins over time, consider special circumstances like the pandemic. Wrap up, I just want to touch on rural hospitals because they are an important part of the equation and something that should be considered as it relates to policy initiatives. They generally do get a certain amount of attention, but they are living in a little bit of a different world. There's always questions about how many of them are closing. Indeed, the creation of the critical access hospital was a number of years ago because there was concern about rural hospital closures. So you can see the split between the older time frame, 2005 to 2019, 2020 to 2022 in red. What this chart won't tell you are the number of service lines that have been reduced at rural hospitals. Labor and delivery and maternity is one of those that gets a lot of attention. But many of these organizations have had to make tough decisions about what services they can offer when they face challenges associated with recruiting specialized staff and the costs of keeping those the service lines open. The other consideration is when they do shut down one service line, it can affect other service lines and their overall sustainability in the market. So rural hospitals are always important to consider, and they're definitely operate in a bit of a different world versus most of the other larger organizations you may hear something about. So in summary, healthcare is expensive. You knew that coming into this, but the hospital share is a big part of it. Expenditures are at about 30% or higher, depending on how you look at it. We've seen a lot of consolidation in the industry, and hospitals are typically in systems. Many hospital costs are fixed, but it's important to recognize that hospitals do have ways to adjust their spending when there are revenue declines, which is usually the concern. There are a number of helpful hospital indicators, but definitely consider them collectively. And always think about how rural hospitals might be operating a little differently. At this point, we're going to open it up to questions and discussion.
Tyler, thank you so much. And Kyle, a big thanks to both of you for being here and sharing your expertise. I'm going to kick things off with a question of my own, and then we'll answer questions from the audience. Remember, you can submit a question at any time by clicking on the Q&A button on the bottom of your screen. So let's begin. I'll start with a question for Tyler. Tyler, we often hear about a particular hospital or health system losing money or operating in the red. But then you might see that they've bought out all the ad space at the local baseball stadium, or they're building a fancy new building, or they just recruited the most prestigious cardiology group in the area. What should we make of that? How can both of those realities coexist?
Yeah, and this goes back to, I think, making sure you're looking at the data over several years. Hospital cost structures, their budgets, or they typically look at, well, what did we spend last year? What do we need to spend next year? But there are sometimes special expenditures or sometimes additional revenues that come in. And those items can change the financial position of the organization for a year or two, some short time window. It's not always easy to see what those are in the financial statements. Often they're noted, but sometimes it's not as clear. So the point is, yes, that there may be special expenditures and maybe special circumstances each year that may change a hospital's financial position. And this is one of the advantages when you start to look at a number of those financial indicators as well, which may give you additional insight about what's going on.
Great, thank you. So we have now a number of questions in the Q&A box, so thank you, keep them coming. We have a question that asks, is hospital profit margin generally hospital specific? In other words, how can we get data regarding the financial performance of a health system versus a particular hospital?
I think Tyler is probably the one who can speak to the more detail, but it does depend on, I will not say that all hospitals or health systems file their financials in the same way. And that part of the challenges that we have had in Colorado is, especially utilizing some of the Medicare cost reports, is that we have health systems that are based out of state Some of their revenues get shared in different ways with their parent companies, which may be based in Tennessee or in Orlando. And that, then we publish things about their margins, and the hospital system says, oh, that's just because of the way we report it, because of the structure of our organization. So it can be challenging. And while there are supposed to be rules about how these things work, there is variation in how different systems do it. And that's been a real challenge for us in Colorado.
Yeah, I would add that, and this question has come up, and just to sort of repeat the way I'm interpreting it, the interest is in better understanding what's going on at the system level. And this can be real important if you look at an individual hospital's financial statements, and if it's too limiting, it actually could show the hospital, well, gee, they made a lot of money, but why are they in a tough situation? Well, they may have investments in physician practices that aren't making so much money, maybe losing, or other sort of entities that they're involved with that may be more profitable or not. So I think the short answer is it can be challenging, and it's not always answered by the financial statements, even though that is really kind of our gold standard.
Thank you. We have another question that asks, given the margins on massive amounts of revenue, how justifiable is it for hospitals to continue to maintain their nonprofit status?
Yeah, this is something that as a policymakers, we have struggled with, I'd say, in Colorado. There are definitely benefits that come from being a nonprofit hospital. And we have, I think, tried to at least create some belts and suspenders on the kinds of community benefits that a nonprofit system is supposed to provide. It is challenging because we have had health systems in Colorado over the last several years that have run 15% margins, nonprofit hospital systems. There's reasons why you need to run a margin, but the appropriateness of that particular margin, is definitely in question. So, the status or the requirements for being a nonprofit hospital are definitely something that we as policymakers at the state level are struggling with.
Yeah, I would add that what's the right margin, and it's and then of course a related question: do nonprofits actually behave much differently than some of the other hospitals? And it's important to recognize they do need to make investments that they use that margin for, I think, from year to year. But at the end of the day, it comes down to the product they're actually delivering. And the basic assumption is that, well, the product, the range of services, the level of technology, the providers involved of yesterday is the best one for the future. And I think that's a good question as to whether or not it should remain the same or we need to make some adjustments. There is a community benefit requirement for nonprofits to report on what they're doing. And those reports are not hugely structured, I would say, but it is a step forward in terms of better understanding the community benefits that are provided by nonprofits. And it also presents an opportunity for the future to perhaps do more on that front.
Great, thank you. We've got lots of questions now coming in, so we'll try to get to as many as we can. We have a question that asks, what is the spread between Medicare and Medicaid reimbursement and private reimbursement? Does this indicate Medicare and Medicaid are underpaying or that private is overpaying?
I think that's a really good question, and one that we have also had to grapple with here at the state level, especially as we have looked at what the appropriate levels of reimbursement are under the public option here. The payment, these often get reported as something like payment to cost ratios. And in Colorado, the Medicare payment to cost ratio hovers somewhere around 70. And when you add in all of the 70%, and in the Medicaid space, it climbs a little above that. There's an argument to be made that, and MedPAC at the national level will make it, that, that efficient hospitals nationally can basically break even, 100% of the on their Medicare payments. Even if you take and you assume that the costs are appropriate, I think there is a recognition that, a lot of times hospital prices are too high. We have hospitals that get paid on average 300, 400, 500% of Medicare. And that is, unsustainable, I would argue, for the market. And that's part of what our public option is trying to do, is to get those hospital payments down into a range that is more reasonable. There's nobody disputes the fact that hospitals needs to make margins, but some of the rhetoric around cost shift and the underpayment of public payers I would argue, is overstated.
Yeah, just to add to that, I think that if you look at different hospitals operating in different environments, and we're going to talk more about this in the next webinar, you will find some that do have a larger share of Medicare and Medicaid. And I think what's been represented by Kyle is similar to my knowledge about where hospitals may land in terms of Medicare as a percentage of costs, Medicaid and commercial. It really kind of, hospitals need to stay within their revenues when they're looking at their costs. So if there's the opportunity to increase their reimbursement levels of commercial payers, in most instances, they're going to take advantage of it. What hospitals don't have something that they would do with additional resources. In fact, some of the statements have suggested that hospitals more recently are focusing on the patient experience much more than perhaps cost control. And there are a number of reasons for that. But when we think about what's the appropriate payment level, certainly Medicare is suggested as, well, gee, there's a lot of sophistication that's gone into the Medicare determined rates. They make adjustments for things like whether or not it's an academic medical center, critical access hospital. Shouldn't we be taking a closer look at what Medicare pays to establish essentially a benchmark? And that's true on the professional reimbursement side as well. In fact, those values have come up as possible indicators for doing things like settling balance billing disputes and other challenges when it comes to reimbursement levels and the appropriate reimbursement levels.
Yeah, the only thing I would add to that is just that what you said, Tyler, in your presentation about sort of the negotiating strength of hospitals, that's a huge determinant of what the commercial price is. And it's basically the single biggest determinant. It really doesn't matter how sick your patients are or what your payer mix is. It's really about how much of a monopoly essentially do you have in your market relative to your payer. And that's what determines your commercial prices.
We may only have time for one more question, and I apologize to everyone that we haven't gotten to, but we'll take all these questions and use them to inform the next webinar in our series. So I'll end the question that asks, what should the media do to better cover hospitals?
Well, that's an excellent question. I feel like that one's for me as the public official. I think that hospital stories, especially in local papers, tend to be feel-good stories. They tend to be stories about people whose lives have been saved. Hospitals do amazing life-saving work, and I've certainly had family members that have benefited from excellent care at incredibly great hospitals here in Colorado. But we do also need to tell the other side of the story, which is, are the costs appropriate, right? Are the prices that are being charged for the services appropriate? The providers will argue that any cut in their reimbursement will reduce their ability to provide care. Certainly, there are levels at which below they could not provide care, but there is also a lot of price inflation in healthcare and specifically in the hospital space. And we need data and a good understanding of what hospital finances are and what their underlying costs should be in order for us to understand how we set the right prices and get costs under control. I'm a big believer in it's the price is stupid argument. that, American healthcare really suffers from a price problem. Yes, utilization is a problem in certain cases, especially on the public payer side. But, especially in the commercial side, we have to get prices under control. That is the uniquely American problem.
Great, thank you. Unfortunately, we're gonna have to end it there. I think, first of all, thank you to our speakers, and thank you to all of you for being with us today. I hope you learned as much as I did. This is the first in a series of webinars on hospital finances. We hope you will join us for parts 2 and 3 on May 17th and May 31st. In fact, you can register for the May 17th webinar now. We've just dropped the link into the chat, and we will send it around with the recording. So please sign up and tell your friends as well. Before you sign off, also please take a moment to fill out the very short survey that will pop up on your screen. Your feedback is really helpful to us as we shape this webinar series. Thank you all for joining us. It's been wonderful to have you.